Good evening. I'm Mark Wagner, and it's 7 o'clock, so I figured time to get started on this, for me, first ever Zoom webinar. I have, although I do a lot of telemed conferences individually like this, I've never done a webinar this way. I do a lot of public speaking, usually to groups of physicians, physical therapists, and patients, but it's always been in person. So this is new for me, so bear with me. I've got 3 screens here because I have a PowerPoint presentation as well as a video to put on, but this is, as you all know, a kind of a crazy new world, and this is the way, at least for now, we're going to need to meet and have larger gatherings. So just a brief history of myself. I have been practicing non-surgical orthopedic sports medicine in the Seattle area for a little over 30 years. I was at the sports medicine clinic for a very long time, which was the oldest and largest sports medicine clinic in the country. We took care of Seattle Mariners, a lot of the collegiate athletes, a lot of the professional football players, and we were like basically a training center to see regional Olympic athletes as well. Then moved on to Northwest Hospital as part of the clinic, and then we kind of became incorporated into the University of Washington as well. I actually left University of Washington about 6 or 7 years ago to pursue a new interest in regenerative medicine. How I got to, oftentimes I have people ask me, how did you get started in regenerative medicine? And it basically came down to one patient who came to see me, who was a patient who had horrible arthritis, severe arthritis in both of his knees. I want to say he was probably in his mid-60s or 70 years old, and had been a patient of mine for years. Came to me with a stack of papers and studies and said, "Hey, doc," he goes, can you do this for me?" So I said, "Well, let me go through this." And I read through this about 10 years ago. I read through it, looked at it, and told him, I said, no, I can't, because at University of Washington, this is not something that we are doing here. And besides, to tell you the truth, I don't even know if it works. So he said, "All right, well, I'm going to go have it done." He actually was scheduled for bilateral total knee replacements. Went to Germany, had it done, followed up with me in the subsequent years, and I was fairly amazed at how well he did after this procedure. He still is doing well without any need for surgery. So I said, hey, there's something to this, it seems like. So with the backing of the University of Washington, I spent about 2 years traveling to different programs, kind of visiting with and working with kind of the gurus in the field, and put together a program at the University of Washington. Unfortunately, leadership at UW changed, and they weren't interested in pursuing stem cells, kind of because the orthopedic departments like to do total joint replacements, and this was not something they saw as a direction that they wanted to head. I therefore left, went out on my own, and opened up Seattle Sports and Regenerative Medicine, and I'm there in South Lake Union now. When we were 10 years old, 1 out of every 1,000 cells circulating around in our bloodstream was a stem cell. When you hit 60, 1 out of every 200 million cells is a stem cell. However, we're lucky in the fact that there are these reservoirs and pockets of stem cells that we can still harvest and concentrate and use to repair damaged tissue. We've done many patients in their mid-90s who do just great. So the stem cells are still there. Yeah, you're not going to have as many as you age, but they still work and they still do what they're supposed to do. The stem cells that we are isolating when we do the procedure are what we call autologous, meaning from the patient. We don't use cells from outside the body, and I'll talk about that more later, the dangers of doing that. And we isolate out what are called mesenchymal stem cells. Mesenchymal stem cells can only grow up to be 4 types of tissue. That's cartilage, muscle, tendon, and bone. Whereas embryonic stem cells are pluripotent. They can grow up to be 200 different types of tissue as they grow up. And these stem cells differentiate and change, and then they are able to, first of all, decrease inflammation, but secondly, regenerate tissue. And the tissue that we're talking about the most is cartilage, muscle, and tendon. So what do we treat with stem cells? Well, there's a number of different conditions. Probably the number one thing that we treat is osteoarthritis. Now, osteoarthritis is basically degenerative joint disease. It's where the Teflon covering of the bone starts to wear down. And that Teflon covering is called articular cartilage. And kind of we grade it as mild, moderate, and severe. And it usually comes about as a result of what we call osteoarthritis, wear and tear arthritis. Could be an old injury, could be overuse, could be genetics. People do also develop arthritic changes in their knees from things like rheumatoid arthritis or lupus or different types of what we call spondyloarthropathies, which can also be treated with stem cells. However, I just wanted to be clear that stem cells are not going to treat the underlying condition of rheumatoid arthritis. They're not going to magically make that go away or make lupus go away, but they do treat the joints that are affected by those conditions. Tendon tears, the tendons that I treat most commonly with stem cells are rotator cuff tendons. Rotator cuff is the four tendons that make up your shoulder, the small muscles that control your shoulder. And in partial tears, or even in complete tears that haven't pulled away from the bone, the way to treat those is with stem cells. We used to treat them surgically going in and suturing up those tendons, but the area where those tendons tear is what's called the avascular zone. So it's got a really tenuous and horrible blood supply. That's why they tear in those areas. So if you go in and you put a bunch of stitches in and try to suture it up, you compromise the blood supply even more. And we know now that 60 to 90% of those surgeries fail within 5 years of the procedure. So that's why putting the blood supply there is the way to go, and that's basically what stem cells do. And we'll talk a little more about the actual procedure soon. Labrum tears. So many of you may not know what a labrum is, or if you've got a labrum tear, you know. But basically, the labrum is the meniscus, and people talk about, oh, I had a meniscus tear in my knee. Well, the labrum is the meniscus of the shoulder and the meniscus of the hip. They're just called the labrum. Those tears also we treat with stem cells. They tend to do very well. There are a couple of conditions that I've mentioned here, such as golfer's elbow, tennis elbow, Achilles tendonitis, patellar tendonitis. Any of the tendinopathies or tendinitises or chronic tendon or muscle issues, I oftentimes just treat with what we call PRP, which is platelet-rich plasma. We're going to talk a little bit more about platelet-rich plasma soon. But if I'm not trying to regenerate tissue, then PRP is oftentimes the way to go. When we do stem cell procedures, we add PRP in with the stem cells, and we're going to talk about why in a little while. But for cases where we're just trying to battle or decrease chronic inflammation that hasn't responded to anti-inflammatories, physical therapy, cortisone injection, PRP works wonderfully for those. ACL tears, the anterior cruciate ligament of the knee. I have treated a number of partial tears in the ACL. They've done extremely well. Complete tears of the ACL, no, because we're not going to be able to put the tendon back together with stem cells. That's going to require a surgical procedure. Meniscus tears in the knee, we treat with stem cells. They do very, very well. Moving on. So oftentimes the patient comes in, just for example, talking about knees, and they've been to see their orthopedic surgeon who said, well, you got bone on bone, you need total knee replacement. The first thing I have to say about that is probably 90% of the patients that I see that come in and say, oh, I was told I have bone on bone, actually don't have bone on bone. And I don't know if they just get that impression or they were told that. But they come in and they're basically looking at a surgical option, which would be a total joint replacement, or what we call orthobiologics or stem cells. So I always like everybody to know the pros and cons of all the procedures that are available to them. So total joint replacement, 70% of patients who have the procedure are happy with the results. But that means 30% ain't so happy. And the problem is you can be worse afterwards. And then we're looking at an end game. You know, there's nothing else we can do. I have people come in and say, oh my God, I had this total knee 2 years ago. It's worse now than it ever was. Can we do stem cells on it? We can, but it's not going to make any difference. So there's no sense to do that. It's a big surgery. It's a lengthy recovery. You have to commit a year to the rehab process. And it's not without potential complications, such as blood clots in the calf, which we call deep venous thrombosis, which can break off and go to the lung, which is known as pulmonary emboli. The prostheses don't last forever, and depending upon your weight, depending upon how solid your bones are, and depending upon your activity level, they loosen over time. So, you know, we say 8 to 15 years, and then they unfortunately have to be redone. And the revisions usually don't end up doing as well as the first procedure. The other thing is now that there was a study out in New England Journal about 1.5 years, 2 years ago, men and women over the age of 60 have 30 times greater and 25 times greater incidence of heart attack and stroke in the 1 year following the surgical procedure. And that is because when you think about it, we're amputating your joint, a lot of bleeding. Subsequently, there's a lot of clotting. Sometimes some of those clots make their way back and can cause problems with heart attack and stroke. The other concern is basically metallosis, which is the leaching of heavy metals from the implants into the bloodstream. And there's concerns about possibly increased incidence of dementia because of that. So before somebody has a stem cell procedure, it's a fairly simple pre-operative procedure. I tell people they got to drink 64 ounces of fluid a day for 2 or 3 days before the procedure. We avoid anti-inflammatories a week before and then for 6 weeks after, because we want inflammation. That's the way the whole process works. That includes, as far as avoiding the anti-inflammatories, things like ibuprofen, Motrin, Advil, Aleve, naproxen, CBD, curcumin or turmeric. And then after 6 weeks, the patients can go back on those. We'll talk about the procedure first. So kind of a typical day. A patient comes in, they draw blood, or my nurses draw blood. That blood goes through a specialized program on a specialized centrifuge and layers out to something called the Buffy coat. We pipette off the Buffy coat. Those are platelets. Platelets are these great little packages of anti-inflammatories and growth factors. Okay. We then have the patient prone on their stomach, and everything is done local anesthesia, although we give the patients usually a little bit of medication ahead of time, a little pain medication, a little anxiety medication. And with local anesthetic, with the patient awake, listening to music, we do a bone marrow aspiration, which we do basically in what we call the posterior superior iliac crest. If you look at the spine and the back on either side is where your pelvis comes up, and that's where we go. We numb down to the bone. We use a specialized kind of a needle, which is called the Jamshidi needle, and we kind of gently kind of work our way down through the hard part of the bone into the soft part of the bone, the trabecular bone, and then we withdraw 50 cc's of bone marrow. It takes about between 1 and 3 minutes. People always are like, oh my God, I hear it's the worst thing in the world. I would say, and I've done 12,000 procedures to date, half those patients are like, are you kidding? You're done already? And half are like, oh my God, I can really feel that. It feels like sciatic nerve pain going down my leg, or it feels like this deep hollow aching sensation. But then as soon as that needle's out, the pain is gone. We then move on and we do a mini liposuction, kind of in the love handle area, very close to where we did the bone marrow aspiration, where we extract fat cells. That takes a few minutes, not painful. 2 very small incisions that are just closed with steri-strips. Why do we get stem cells from bone marrow and from fat? So, according to a good friend of mine who ran the molecular biology department at Stanford, the reason being the stem cells we get from bone marrow are pretty much immortal. The stem cells we get from fat are prolific. We get tons of them. I like using the matrix of the fat as well because it's a good matrix to help those stem cells adhere to the bony structures that they're going to try to lay down new cartilage on top of. So the stem cells from bone marrow go through another different computerized centrifuge program. The stem cells from fat go through yet a different one. We then end up with 3 syringes, 1 stem cells from bone marrow, 1 stem cells from fat, and 1 platelets. Then, under ultrasound guidance, we inject those into whatever joint we are looking at, which takes a couple minutes, if that. That part is usually not painful. It can be a little stingy for maybe 10 or 15 minutes. Patients walk out, somebody else drives, and then we usually start physical therapy 3 to 5 days later. We want people walking. Who do we not do the procedure on? Anybody who has an active cancer is being treated for cancer with chemotherapy or radiation therapy. Patients who are on blood thinners, and I say that that we don't treat patients who are actively on blood thinners, but 99% of the time, the patient's internist or cardiologist has told them, hey, if you need to go off your blood thinners for a couple days prior to a procedure, that's not a problem. So we have the patients check. If you're on something like Eliquis or Xarelto, it's 2 days, and then you take it right after the procedure. If it's warfarin or Coumadin, it's 5 days. But not a big issue. Most patients have no problem being off of it for a few days. If somebody has an active infection, pneumonia, they've got a skin infection or cellulitis, or they've got bad sinusitis, we put off the procedure or wait till that's taken care of medically. So this is just a warning. Wherever you end up having this done, I want you to be really, really careful about who you go see. There are a lot of bad actors out there in the community who are kind of giving stem cells a bad name. There are groups out there, oftentimes they're chiropractors, naturopaths, who hire nurse practitioners to do the injections and buy cells online, basically. Buying things like amniotic fluid online or embryonic cord blood online. A lot of it comes from Mexico, comes from women who are willing to sell their placentas. And we know now that in amniotic fluid that's frozen and transported, there are 0 live stem cells in there, and God only knows what else. I had one case when I was, before I started here at ProLiance, that one of my partners saw, had seen one of these clinics, had this procedure done. Unfortunately, ended up with a bad infection in his knee. They worked for probably a month. They took him to the OR 3 times, cleaned it out, put a permanent IV line in, gave him IV antibiotics. Ultimately, he ended up with above-the-knee amputation. So I just want you to be really careful about where you go to have this done. You want to see, a board-certified physician who's done thousands of these. So that is really important that you don't get drawn into a lot of these fly-by-night kind of operations that are given those of us that have been doing this for years a bad name. Okay, results. Basically, in patients who have mild to moderately severe osteoarthritis, those who have partial rotator cuff tears or meniscus tears, big data says 85% of patients get at least 80% better. In my hands, 12,000, a little over 12,000 procedures, we are at 91%. of our patients get at least 75% better. So, and those are what we call PROs, or patient-reported outcomes. The big data comes from a number of universities out there that are doing it. This is a procedure that's being done. It's been done 16 years basically in the United States. And if you look at all the major centers in the country, they're doing stem cells. Mayo Clinic, Cleveland Clinic, Stedman Clinic, Kerlan Jobe, Duke, Stanford, Cal. They're doing it all over the country. There are certain areas of the country where stem cells are not being done in large numbers, let me put it that way. South Florida, California, Texas, Colorado, New England, there are tons of practitioners doing stem cells. It's kind of been a little bit behind in the Northwest because they're not doing it at the University of Washington. As far as results go, so worst case scenario with stem cells, you fall into that 9 to 15% bucket. That's the worst case scenario. And what happens is you don't get significantly better. Nobody gets worse. So, because we're using just your cells that come from your bone marrow, your fat, and your blood. It's a very, very safe procedure. There have been in excess of 50 million cases done in the United States. The FDA monitors all of them on something called the MAUD database. And as long as you use your own cells, there hasn't been a single serious adverse event reported. So that's the FDA MAUD database that we're just talking about. So after the procedure, patient walks out. They're given medication if they need it for pain. We talk about icing, elevation. We want people moving around. We want them up and walking and moving, and usually instruct people and make sure they have an appointment with a physical therapist to see them within 3 to 5 days to get started on. The small little incisions we do on the back, we take the dressing off at 24 hours. The little steri strips fall off whenever they fall off. The first 2 weeks are what we call activities of daily living. Most people go back to work the next day, unless you're a police officer, a firefighter, or you're playing offensive line for the Seahawks and whatever. I mean, it all depends, what you're doing as far as lines of work. But most people who have, fairly sedentary jobs, or if they're just walking around or at desk work, it's usually they're back the next day. Most patients start to see significant improvement 6 to 12 weeks. Improvement usually goes out to about a year and then tends to level off at a higher set point. Well, there is some data out of Japan that says that goes out to 2 years and then tends to level off. Sometimes what we will do is at 3 months, put some more platelets in the joint, which is the PRP, which basically I use the analogy of looking out in your backyard and seeing that bare spot on your lawn. 3 months ago, you put seed and fertilizer on it, and now you look out and there's grass growing there, but maybe it doesn't look as good as the rest of the grass. So sometimes you put some more platelets into the joint, which is just the blood draw portion. It takes about 15, 20 minutes. Not everybody needs it. I'd say about 20% of the patients end up wanting to do PRP at about the 3 to 4 month mark. Physical activity, usually by the second week, we have patients back on a stationary bike and then progressing to an elliptical. Most patients, by 6 weeks, we can get back to easy golf with a cart, easy skiing, easy hiking, and that's only because in the first 6 weeks, those cells are kind of fragile. We don't want to disrupt them. We don't want to shear them off the surfaces. By the time you get to 12 weeks, everything is stable, and I tell patients, whatever you feel like you can do, go for it. So I was just going to kind of go over the different joints that we do. It's not necessarily in order of the most frequent, but I'd say shoulders, probably the third most frequent joint we do. Second patient I ever did about 6.5 years ago was a guy who had horrible arthritis in his shoulder, complete rotator cuff tear, couldn't lift his arm more than about 45 degrees for 15 years. He was a 70-year-old contractor, worked 7 days a week, and that's all he loved, working. And he actually came to me, and I sent him to one of my partners. I said, "Oh my God, Bob, your shoulder is just terrible. Can't even see the joint." And so I sent him to one of my partners to talk about a total shoulder replacement. My partner sent him back to me and said, "Mark, if I do a total shoulder on this guy, he's going to hate me for the rest of his life." So Bob said, "Doc, what about stem cells? Why don't we try stem cells?" I said, "Oh my gosh, your shoulder is so bad, Bob. I can't guarantee anything, and I can't even say that you got an 85% chance of getting better." But he wanted to do it. We did it. 4 months later, he came back to see me. He said, "Doc," he goes, "you're going to laugh." He goes, "Look at this." He goes, "I haven't been able to do that for 15, 20 years. I'm sleeping through the night with no pain. Same thing. I haven't done that for 15 or 20 years." And he continues to do well. I hear him talking to Dave Ross on the radio all the time about how well his shoulder's doing that. Maybe after he works overhead for about 15 minutes with a pneumatic nail gun, he starts to get a little bit of aching in his shoulder. Elbows, that's for the most part, we're treating like tennis elbow, golfer's elbow, and we do that with platelets, PRP. Occasionally, I do have patients with osteoarthritis in their elbow, although it's one of the least frequent joints that we treat, but they do very well with stem cells. When I talk about wrists, primarily I'm talking about the joint at the base of the thumb, which is called the first CMC joint. It's a very common joint to get arthritis, and it responds very, very well, as does the corresponding toe joint, where people get bunion deformities. They do really well with stem cells. They're small joints. We don't put fat in them. We just put bone marrow in them. Speaking from experience, 6.5 years ago, everybody on my mom's side of the family has arthritis in the base of their thumbs, as do I. I was having not difficulty, but pain doing procedures and examining patients. I was having my partners inject my thumbs every 3 or 4 months with cortisone. I said, finally, heck with this, I'm going to go see somebody and have this done. So I had stem cells done on both of my thumbs. I'm happy to say I'm 100% improved on my right after 6.5 years and 85% improved on my left. Hips are the second most common joint that we do, and they also respond very well. They're not as large a joint as a knee, so even though we put about the same amount of cells in there, can be a little bit uncomfortable because it feels like a balloon getting ready to pop. But the more cells you get in, the better the results are in the long run. Knees, the most common joint we do, and it's the one where we see very good results with knees. Oftentimes, patients come in and both knees are involved, and they've got not only osteoarthritis, but they got meniscus tears, and they know somebody down the street who had a horror story with a total joint replacement, and they come to me and say, "Doc, there's no way in hell I want to have surgery on these joints." I'm even seeing patients now getting a lot of referrals from orthopedic surgeons and internists, patients who have severe, horrible osteoarthritis that normally we would go on to do a total joint replacement, but they're not candidates for it. Either they're obese, or they've got heart disease, or they've had a stroke, or they've got terrible diabetes, and the surgeons don't want to touch them, so they'll say, go see Wagner and talk about stem cells. I tell you, we've been very pleasantly surprised at the results that we're seeing, even in patients with severe arthritis. Ankles, by the time ankles get to me, the patient is usually between a rock and a hard place. They've been given the option of, let's fuse this ankle joint, or maybe if you're lucky, you might be a candidate for a total ankle replacement. Neither of which is a very pleasant option. So people come to me and to talk about doing stem cells. And I have to say that most people do very well with stem cells, even though they're at a fairly advanced stage of arthritis in their ankle joints. That is pretty much all I have for now, but what I'd like to do is open it up for questions, and I've got one of my go-to physical therapists here with me today. So if there are questions for therapy, Vicki would be happy to answer those. If there are questions for me, we'll kind of look at them as they come up on the board, and we'll fire back. Okay, so First one, why aren't insurance companies covering stem cell procedures? Is there any indication that they will be covering this in the near future? A lot of it has to do with politics. And basically, orthopedics tends to run a lot of hospitals. Orthopedics is the big moneymaker for hospitals. Hospitals, ambulatory surgery centers, and surgeons who just do total joint replacements don't want to see this procedure, supplanting their big surgeries. It's kind of like the old saying that, if all you have is a hammer, everything looks like a nail. So, the surgeons like to do total joints, and they do make a lot of money for the hospitals. The prosthetic companies also, so there's this big push to do total joint replacements. Will insurance be covering it? Eventually, I'm pretty sure it will get covered, although I talked to a couple guys from Regents a few months ago. Actually, it was in March. It was right before COVID, and they're on the board at Regents, and they didn't say, it wasn't even on their radar screen yet. So let's see. I work in construction every day, and I'm lifting and bending and so on. What kind of recovery time would I need in order to return to work? Okay. Basically, walking around a job site, going up and down stairs, it should be fine after a day or so, if you can get help. And yeah, I don't want you lifting really heavy stuff. I don't want you having to do squats and kneeling down and a lot of shearing forces, on your knee. I assume we were talking about knees. It doesn't say, but it all depends on which joint we're talking about. But there would be, some restrictions for a period of probably about 6 weeks. Then usually we can get back. Although I still probably wouldn't be doing like having to lift down and lift, 5,800 pounds, and be going up and down stairs with something. But it's usually something, we can work with and make it work. Okay. So I have a sprained ankle that after 1 year is not getting better. Do you think stem cell therapy versus another type of injection would be best? What you might have going on, it might not be just a sprained ankle. So typically when I have patients come in with even bad ankle sprains, if they're not better by 12 weeks, they need an MRI, because it could be that there's what we call an osteochondral defect. In other words, a chip, a crater through the bone and cartilage that is something that responds really, really well with stem cells. But that's something that we would be able to, sometimes you see them on an x-ray, but it can take a while. And so in other words, if you go into your physician, he takes an x-ray and says, it's a sprain and doesn't see anything. If patients are still painful at 6 weeks, I'm going to repeat the x-ray. And then if they're still painful at 12 weeks or even shorter than that, I'm going to be pretty aggressive and get an MRI to see if there's something else going on inside that ankle joint. If a knee replacement lasts 7 to 15 years, how long do stem cells last? Okay, so it varies tremendously. So it depends on where you are in the course of the disease process, weight, genetics, and how much stress you're going to put on those knees. I can think back to one guy I did about 6 years ago. Both knees had moderately severe arthritis in both knees, but he was an ultra marathoner, and his bucket list goal was to finish the Western States 100 in under 24 hours and get the special belt buckle that comes with that. So anyhow, I did his knees. He continued to train. Came back to see me after about 2 years. He said, "Doc," he goes, I want to do it again. I said, "Oh, what happened?" He goes, "Well," he goes, "I'm thrilled. I did the Western States 100 in under 24 hours, but now my knees are sore again." He goes, I really want to do them again. And I said, "You got to promise me that there's no more running, that we're going to just cycling, swimming, elliptical, gliding motions." He said, "Doc, I'm done running." He goes, I got it out of the way. And so we did him again. He continues to do great. But it all depends. I mean, Barbara Bornstein, one of the people who's been doing this for 16 years at Harvard, she's got patients who are out 16 years from doing it. She also has patients, and she said, you know, every once in a while, I'll see somebody who was scheduled for total knee replacements, and they'll come back in at 10 years and say, Doc, it's been great. They're starting to bother me. Can we do it again? Yeah, we can do it again. So it can be repeated. Okay. Why is PT necessary? I'm going to throw Vicki in for this one because she's my go-to person when it comes to PT.
Hi. Why is physical therapy necessary after stem cell? Well, several reasons. One being that you've been inhibited because of pain. And now often we see patients even the week after stem cell and most of their pain is gone, but they have weakness in the muscles around the joint. And so we work aggressively on improving the strength in the area. Another reason is to really focus on the other losses that the precipitating factors have created, which is usually a balance condition. So we want to improve the proprioception so that you know where that joint is in space and you don't go and re-injure it and end up in a situation where you are going to need potentially to see Dr. Wagner sooner than later. And then we look at how much space does that joint have, and if the reason for the stem cell injection was for cartilage, we know that cartilage really hates having too much compression. So if you have a really tight, stiff joint, you may need physical therapy to improve the range of motion in that joint so that there's plenty of room for the stem cells to do their job and make, I always think of baby stem cells that then grow into mature cartilage and has the necessary room to have a good outcome.
Okay, so let's see. The average cost for a shoulder procedure, I got two questions. I'll try to answer them together. One is, what's the average cost for a shoulder procedure? And the other is, what's the typical cost of PRP and stem cell injections? So a large joint, to do stem cells, and when I say to do a stem cell procedure, that includes stem cells from bone marrow, stem cells from fat, and platelets. A large joint is $7,000. To do PRP, it's $1,100. When we do the stem cell procedure, that includes PRP, but if we just do PRP on its own, it's $1,100. Now, smaller joints are less expensive. I'm trying to remember. I think a small joint, like a thumb joint or a big toe, it's in the $3,500 range, and it varies all over the country. If you look at, I did a lot of training down at Stanford and also at USC. And the guys in private practice down there are charging $15,000 a joint. So be careful. There are also people here in Seattle who are charging ridiculous amounts of money and who also say, well, we got to do IV stem cells, which is very sketchy and could be dangerous as well. Now, granted, we are doing IV, I say we, meaning the medical profession. There is some IV stem cell therapy used in studies looking at treating Alzheimer's, dementia, and ALS. However, to be done in somebody's office, and they usually use it from fat, there's really been no studies, nothing that shows any significant improvement or any benefit to doing IV, number one. Number two, be very careful about people who say, well, we're going to freeze your stem cells, we're going to bank them. It needs to be at a certified cryogenics lab. There's a lot of legal issues with that going on right now as to whether or not you really even own your own stem cells. It's going to go to the Supreme Court, but everything is basically in abeyance right now, so people cannot even get their stem cells who froze them from years ago. So be really careful about those things, the IV and the banking, and be careful about the costs because there are some ridiculous charges and costs that I've had patients come to me and say they went to see, so-and-so here and wherever in the Puget Sound area, and they're going to charge me X amount of dollars, and some of it just, I don't know, just makes me angry. But so be really careful about, what you look at as far as procedures go. All right. Should it last a lifetime for tendon repairs? If it's regenerating the torn tendon, isn't that a permanent feature unless you have another acute injury? Yes. If somebody has a big injury to like an Achilles tendon or a patellar tendon, I've done a number of tennis players with patellar tendon and Achilles tendon problems. If there's no damage to the tendon that I see on an MRI, I just do PRP. They do great. If there is damage to the tendon, I'll do stem cells and PRP. I've had one total knee replacement. Now the other is bone on bone. I've had cortisone shots and most recently hyaluronic acid shots. The latter have helped a bit, but my provider says a replacement is the next step. Am I likely to benefit from stem cell therapy? So first of all, my first question would be, is it truly bone on bone? So that's something I usually look at with images. The cortisone injections, I don't do cortisone injections in knee joints. And the reason I don't is because it's very limited benefit, maybe a couple months if you're lucky. But in the long run, it breaks down the cartilage even more, makes the osteoarthritis worse. Well, for years and years and years, the surgeons, and still do, they don't, it's like, all right, let's just inject cortisone in there. Maybe we'll give you a couple months of relief. And, we don't really, it doesn't matter if it makes the joint worse because we're just going to replace it in the future. So yeah, I would look at your options and see. You may be a very good candidate for orthobiologics. I mean, basically when patients come to my office, that's what I'm evaluating. And if somebody's not a good candidate, I'm going to let you know that. I turn away just as many people as we, offer the procedure to, because I want people who are going to do well. And if somebody comes in and I think, and they really want stem cells, and if I don't think it's going to be a good option for them, I'm going to let you know that. Okay. Do you also do stem cell replacements in somebody with degenerative disc disease and osteoarthritis in the facet joints of the back? No, because I am too busy doing joints right now, but I do have some people that I use in Vegas, Denver, and Portland who do a very good job with spine. There's nobody up here really doing a good job with spine. Next question is, what about psoriatic arthritis? If this treats the joint but not the underlying condition, is the procedure worth it? So psoriatic arthritis, yes, it works very well for the joint, just like it will in osteoarthritis. Now, it's not going to change the autoimmune, basis for the disease, but what it can do is it can regenerate cartilage and put you at a much higher level, so put you back to maybe where you were a number of years ago. Granted, the psoriatic arthritis is still going to be causing an issue, so it may be that we put you at a higher level set point, and then over time things might start to slant or edge downward because of the underlying disease process. However, we've done a number of patients with rheumatoid, psoriatic arthritis, ankylosing spondylitis, and they do very well. Now, it's, once again, I say it's not going to take away the autoimmune basis for the disease, but it's going to treat the joint. Next question was, can you do 2 joints at the same time? Yes, we definitely can. That's 2 large joints is the maximum we can do because there's 2 sides to your pelvis, and that's where we get the bone marrow. And after 50 cc's of extraction of the bone marrow, we start to see diminishing returns on stem cells. So I won't take more than 50 cc's from one side. But 2 joints, yes, you do the therapy at the same time. I mean, it's not like you're laid up like doing 2 total joint replacements at the same time. The other thing is it does save people a lot of money because we're able to combine the kits, the surgical kits. Whereas 1 large joint is $7,000, 2 large joints is $10,000. So you're saving about $4,000. Okay, so next question. I'm a 72-year-old male in relatively good health. I had a hip replacement 13 years ago and it's doing fine, but I don't want to go through that again. My other hip is starting to bother me. I have been on statins for several years. Does this affect my ability to undergo stem cell therapy? Not at all. Statins are fine. The only medications that would affect it, as we talked about earlier, are blood thinners, and typically we can take people off those for a few days. Let Vicki jump in on this one as to whether or not you, I recommend physical therapy beforehand.
What do you?
I do. I think it's a good idea to get people, in good shape, and the more strength you can get going in, the easier the rehab process is going out.
And that's what we see clinically too. People who do the prehab for most conditions are going to do better because part of the process is having good blood flow, and the more access you have to your muscle system and the ability to contract and relax is going to facilitate a lot of blood flow through the area, which will make the process hopefully quicker.
I totally agree on that. Okay, we've got a long question here. I was T-boned in a car accident 3 years ago. I have a metal plate and 19 pins and screws in my left ankle. The past year, I have taken a step back and have suffered unbearable pain, which prompted me to see my surgeon again. I just had a CT last week, and it referenced tibio-talar degenerative joint disease. From what you've said, I may be a potential candidate. My surgeon says I'm too young for replacement at age 56, but I'm desperate. Stem cells sounds more of what I can benefit from. Help. Yes, I mean, I think definitely we don't want to talk about a fusion or an ankle replacement at age 56, and there is a very good chance that you're a good candidate for stem cells. So I'd say, if you're somewhere closer, I mean, we see people from all over the world, but if, set up a time for a consult and we can kind of look at those images and be able to talk a little more intelligently about what, your percentages are at getting good improvement. A couple of questions on where are the procedures done there. We have a procedure room in our office. Our office is totally compliant with COVID regulations. The nurses and staff prep every room before and after every patient as far as sanitizing everything. The procedure room is a sterile room. The kits are all sterilized. I do not see any patients with COVID in the office. If there's any question about that, we do it all on a telemed. So, and we're not in a hospital. We're not in a clinic. We're in a separate building in South Lake Union. So it's a very safe, sterile, clean place to have the procedure done. Okay. All right. So I've had 2 knee operations for torn meniscus. Last one this year, but the other one from years ago shows signs of arthritis, but no physical symptoms. Could this be a preventative procedure against further arthritis? Yes, definitely. So one of the pioneer in stem cell therapy, one of the women at Harvard, her big issue is you jump on these as soon as you can before the horse is out of the barn, because the sooner we jump on arthritic problems, the better people do in the long run. And, oftentimes I love when I can tell somebody and they come in, I say, there is a very, very good chance we're never going to have to talk about a total knee replacement or a total joint replacement or potential further surgery in the future. How long does an evaluation take? And if a candidate, how long is the wait for the procedure? Can I do post-procedure PT locally instead of going to Seattle? Absolutely, you can do it locally. So we don't want people having to drive down to Seattle to have physical therapy unless you live in Seattle. But yeah, we know physical therapists all over the state and for the most part all over the country that we refer people to have their physical therapy done. The actual consult evaluation usually takes about 45 minutes. And then as far as the wait for the procedure, right now we're probably, usually do that to the front desk, but I'd say about 4 weeks out. And so they've been, my front desk staff has been telling me, yeah, you know, now we're 4 or 5 weeks out. So I have actually started to add in Wednesday and Friday afternoons. We typically do procedures on Tuesdays and Thursdays. So we're trying to be able to accommodate and get people in sooner so they don't have to wait such a long period of time. The price for a consultation, it's somewhere, depending upon whether we need to get images, x-rays, it's in the $300, like $350 range, but 99% of the time that's covered by your insurance. The only thing that's not covered is the procedure, but consults are typically covered by insurance, as is physical therapy, as are follow-ups. How long do you need to do PT for stem cell therapy? I start people off twice a week for 3 weeks, and it all depends. Some people are like, that's great, or I didn't even feel like I needed that much. I'm doing so much on my own. Some people come back and they say, or they'll call me, or the therapist calls me and says, you know, they're doing okay, but I think we need a little more therapy. So sometimes we might go 6 weeks, 9 weeks, as long as the patient feels like they need it. All right, well, I hope I've answered everybody's questions. If anybody out there wants more information, there is a PDF of our brochure and the questions and a whole bunch of packet information. And in order, if you want to get that, what do they do? You would just need to email events@irgpt.com. That's events@irgpt.com, and they'll send you out that PDF. And then if anybody has any questions for me or wants or needs a consultation, my information is, I don't know where, it's somewhere out here. Oh, it's on, they just email to same thing? Or, it would also be to events@irgpt.com. Or you can just, it's easy in these days of social media to just go to seattlesportsclinic.com, or you can just punch my name in, Marky Wagner MD, and the clinic website will come up. There's a very informative and large website that has many patient testimonials, a lot of professional athletes, as well as weekend warriors and such. But yeah, and then as far as for consultation goes, all you need to do is call the office number, which is 206-620-0333. I'd like to thank everybody for attending. I hope I did a pretty good job on my first webinar, and maybe I'll do some more in the future. So I hope everybody stays safe out there, and have a good evening.